Hi, everyone. On behalf of GU Oncology Now, I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University. I'm pleased to be joined today by an expert panel of kidney cancer experts, and we're going to talk about really the spectrum of therapy for frontline kidney cancer, from observation and drugs, and also some of the new data, including triplets and what will be coming out in the next year. So I'm going to have each panel member introduce themselves, and we'll start with you, Dr. Ornstein.
Hi, I'm Dr. Moshe Ornstein. I'm a GU medical oncologist at the Cleveland Clinic, where I spearhead the RCC efforts.
Hi, I'm Shuchi Gulati. I'm an assistant professor at UC Davis Comprehensive Cancer Center. I'm really excited to be here.
Monty Pal. I run the kidney cancer program at City of Hope in Los Angeles.
Great, thanks all for being here. I'm going to jump ahead here to a trial we haven't heard about yet, which is 8Y8, which is Nivo versus Ipi-Nivo. Because the question is really around the role of Ipi, and I think it's sort of waxed and waned a little bit in RCC, where it's super important. There's definitely a tail to, I'm not really sure. We see this Nivo monotherapy data look pretty good, right? It looks pretty darn good. Smaller study, not big randomized. And so, I don't know, Monty, maybe starting with you. 8Y8 is Ipi-Nivo versus Nivo. We haven't seen data yet, but probably should in the next year, maybe in the next 6 months. Predict what that trial's going to show.
Okay, all right.
And if you think the results, whatever that may be, are really going to shift the field, or is it going to be, if I'm an Ipi-Nivo user, I don't care, it's a small study, I'm still going to use it. You know what I mean? Is it going to make people shift their treatment patterns?
Yeah, I think there's going to be an advantage with Ipi-Nivo over Nivo monotherapy, and the reason I'm suggesting that is that, if you look across all of these, single arm experiences with monotherapy with IO, I think the high watermark might be, Dave's data, with the pembrolizumab with response rates in the 30% range, right? So I don't see us getting to that, mark of 40 to 45% with Nivo Ipi. And that's in the context of, international phase 3 clinical trial, right? So, my prediction is there's going to be a benefit there. The degree to which we see benefit is going to be, questionable. But even with, is it a non-inferiority study? Do you have to know?
I don't think it's non-inferior. It's not big enough.
Yeah.
I don't remember if it was PFS or OR. I honestly don't remember.
Right.
But it's fairly small, which is a problem.
Yeah.
Smallish by phase 3 standards. I think it's in the 450 range. So
got it.
The power is limited.
So that's an issue, because I predict what we're going to see is perhaps, an advantage with Nivo Ipi, but even if it's non-significant, I'm still probably going to favor that over monotherapy frontline.
Yeah.
I mean, you're still going to end up with the same question. If there's a marginal benefit to Ipi-Nivo, then the Ipi-Nivo believers will say, well, the marginal benefit may hold out to the very end, and that's why we're giving this combination. And we're not going to have that with Nivo monotherapy. We'll see. But.
Or there might probably, the question about what's that specific population that did derive benefit. So I don't think this argument will go away, because maybe we'll see a bigger benefit for patients who have sarcomatoid histology, and I'm probably not going, or maybe, so I think this discussion will probably still happen, although we'll have more data then to.
Yeah, no, and I think it's a fine trial. I agree with basically the consensus that there will be some small differences, maybe a 5% response rate difference, and I don't know, PFS, will be 3 months more. There won't be a survival difference, and that tail of the curve we're certainly not going to see with initial data. So to your point, Moshe, we'll have to wait and wait. And if you're in the Ipi-Nivo camp, this will not take you out of it. And if you're in the IO-TKI camp, this will not put you in it.
Yeah, I think the question is, does it change the minds of the regulatory authorities overseas?
Right, and that's why it was done. Yeah. So, but stay tuned for that.
Well, this whole dialogue around contribution of components with immunotherapy is so interesting, because I think we're starting to enter into this era where you have components like LAG-3, which as monotherapy probably don't do a whole lot, but they're intended to really sort of augment, right, the IO backbone that they're put upon. So I think there's going to be a lot of this down the line.
As we get more immune drugs.
Right.